Hello, everyone. Before I get started talking about the information that's on my slides, I wanted to go ahead and give some background information as to my motivation for this research. Oh, I also wanted to thank ICTAS for supplying my funding for my grad student for this year. Also, as a new assistant professor, every bit counts, certainly, so it's been very helpful. So before I came to Virginia Tech, I was a postdoc at UNC Chapel Hill, where we basically developed medical devices to do local cancer therapy for breast cancer as well as pancreatic cancer. And so what we were working on back then was actually to deliver standard pharmaceuticals. In the case of pancreatic cancers, gemcitabine. What we basically learned is that unlike other cancers that are very vascular, have a lot of vasculature, pancreatic cancer is unique in that there's this stroma that forms over the tumor that actually prevents a lot of drugs from actually getting into the tumors. And so unlike other cancers, pancreatic cancer is very poorly vascularized. And so a lot of the drugs that people are developing that they want to deliver systemically, they're never actually even getting to the tumors. And as you know, pancreatic cancer is a very devastating disease. The 5-year survival rates are really, really poor. And so I thought it would be really interesting to try and capitalize on some of the resources and ideas that I had when I was at UNC and see what people were doing here at Virginia Tech and see what we could try to come up with to tackle this big, dire problem. So I'm very interested in translational research. As a graduate student at Rice, I worked a lot with MD Anderson, and in my postdoc at UNC, I worked with a lot of clinicians there also. So one of the first things I did when I got here with my graduate student was to go to Wake Forest and to talk to some doctors who basically work with patients that had pancreatic cancer. So Perry Shen's name is mentioned up there. He's a surgical oncologist who does a lot of GI surgeries. I met with him first, and he was suggested to me by Chris Rylander, actually. And I met with him and told him what the ideas were that I wanted. I really wanted to do a minimally invasive device to be able to do photothermal therapy with nanoparticles. And so I asked him if this was something that would be compelling, and he seemed very interested in it. He told me I should talk to Girish Mishra, who's listed up there also. Girish Mishra is actually the director of the GI endoscopy unit over at Wake Forest. And so I had a pretty lengthy phone conversation with him where I talked about my interest in being able to do these local cancer therapies based on some of the work that I did when I was at UNC. So he thought it would be really exciting to do this kind of work, but one thing he mentioned to me that was surprising is that diagnosis is also a problem for pancreatic cancer. So he does endoscopic ultrasound, so of course they feed the endoscope down through the esophagus, and through the small intestine they'll take a needle and then probe the suspicious lesion and take a biopsy sample out. So oftentimes they don't get the information that they want to get. When they take the biopsy sample out, it's not enough tissue, so it ends up being inconclusive, and they end up having to repeat the procedure. Another problem is that when they do these procedures, sometimes you can induce pancreatitis, which is, of course, inflammation of the pancreas. So it's also a very big problem for that reason. So he said, if there's any way you all could come up with some way to do diagnosis in addition to doing treatment, that would be really, really great. So I said, well, that will be, I was already thinking about doing medical devices that had combinatorial technologies for different types of therapy, like photothermal therapy and irreversible electroporation. So now he was talking about doing diagnostics as well. So the question is, how are we going to create medical devices that can do all of these things in one modality? So normally when you think of diagnostics, of course, you think of nanoparticles. And I am also exploring looking at different nanoparticles for doing diagnosis and treatment. And I've actually been looking at using gold sulfide nanoparticles for the photothermal therapy of cancer in addition to developing these medical devices. So gold sulfide nanoparticles, I just wanted to briefly mention a little bit of something about them. It's actually a particle, the system that I worked on at Rice University. Some of you may be familiar with gold nanorods. Gold sulfide nanoparticles have very similar absorption efficiencies as nanorods. They're about 98% efficient. But unlike gold nanorods, they don't have the CTAB toxicity concerns, and they're not a pain to make like gold nanorods are, which I've made both of them, and gold nanorods are pretty hellish to make. So gold sulfide nanoparticles, I think, are just really awesome. So I've decided to we've started developing those in my lab as photothermal therapy agents. So as far as making the prototypes, there's varying complexities that we want to do. Some of them are the lower hanging fruit than others. The ultimate goal is to be able to create a device that can do diagnostics and also do a combination of either irreversible electroporation at the core of the tumor as well as photothermal therapy at the tumor margins using nanoparticles. And I've talked extensively with Chris Williams and Chris Rylander, and recently Rafael Davalos. We're basically forming a team where we can really work hard to get these devices to come to fruition. So one thing that I learned during my exploration of why local therapies are important, oftentimes clinicians will have the attitude, well, this is a metastatic disease, so local therapy doesn't matter. But the fact remains that even if you have a systemic drug that can take care of metastatic tumor, you still have the primary tumor to deal with. And if you don't kill all the cancer cells, or you don't take all the cancer cells out of a primary tumor, you're just going to have metastatic cancer all over again. So one thing I came across when trying to support why it's important to do local therapies, I came across this interesting research field of being able to induce anti-tumor immunity through the use of photodynamic therapy and doing that treatment locally. So it's a pretty broad area as far as there's not a lot of research being done, photothermal therapy, and whether or not you can induce anti-tumor immunity, or even doing irreversible electroporation and some combination with photothermal therapy. So I actually applied for the ICTAS JFC award because I'd like to get started doing some work on this anti-tumor immunity and photothermal therapy, because I think it's a pretty big field, and that we could be the leaders in doing something with that, because there's really not a lot of work being done in that right now. So again, just to reiterate the key points, is the goal is to develop a theranostic system using devices as well as nanoparticles in order to develop a system that can do diagnostics and treatment in one modality, and hopefully even incur anti-tumor immunity and prevent recurrent cancer, which I think would be really huge if we could do that. And obviously for other cancers other than pancreatic. So what we've been working on up until now is first developing our gold sulfide nanoparticles, which my grad student has been making over the last few weeks. We're at the point where we're now ready to start optimizing the fabrication process and doing some characterization. A lot of people, there's not a lot of people working on these nanoparticles, but those who have done some work on them, there's not really been a lot of characterization done and really optimizing these nanoparticles so that they may one day actually be put into the clinic. The other aspect has been developing these medical devices. So we worked really hard in the beginning brainstorming all of these different ideas and iterations of what's feasible, what can we really make happen. We started with standard needles, whether we could cut them and put holes in them. We bought all sorts of crazy engineering type tools to do things. But what we ended up deciding is that the best way to try different prototypes is actually to do 3D printing. So it's been very fortunate that I've had Chris Williams next door to me, because I can just pop in and ask him random questions all the time. 3D printing these prototypes makes it easy to change all these different factors and then actually have a product that you can look at and decide what it is that you need to change and fix to make it actually feasible. So the one thing about pancreatic cancer and doing any kind of imaging or treatment with a probe, diagnostic treatment probe endoscopically, is that you're limited to a 19-gauge needle. So it's pretty small, obviously. And one key of being able to do this successfully is to have basically a diametrically consistent tool to be able to do your different imaging and diagnosis and treatment strategies. So this image on the cartoon on the left, basically shows just a cartoon that my grad student put together, where we basically have the black represents the regions that are non-conductive, and the blue would be the regions that are conductive. So one great thing about 3D printing is after you print your product, you can also plate these different segments with metal. And that's something I'm working on with Chris Williams to get that to happen as soon as possible so that we can complete our first successful prototype. Oh, that cartoon did not show up. So there's supposed to be a cartoon showing a cross-section of, this would be the SolidWorks image, and at the top was supposed to be a cross-section of the image of the CAD drawing showing the needle. Basically what we have is a base needle that is hollow all the way through. With that hollow chamber, we can basically feed fiber optic microneedle devices. The objective is to be able to work with Crystal Rylander and be able to put these FMDs through the center of that to be able to do photothermal therapy and co-delivery of the nanoparticles. And then we basically have these different components that you can slide over the needle base, over the shaft, and these components can be conductive, such as this blue one would be a conductive part, and then non-conductive. Now what you'll see by looking at these pieces is that the inside is actually what's unique about the design, is that you can basically feed electrodes down these cutouts in the components, and basically prevent crosstalk between the two electrodes, which is pretty important when you're trying to do any kind of electrical iontophoresis or electroporation of your system. Another thing is the plated system. The plated components have these protrusions that are kind of sticking out on the end, and that's really to facilitate the soldering of the electrodes, so you don't have to worry about trying to internalize being able to do that. So we actually have a big prototype. This is a 10x compared to what it would be for 19 gauge. And that's just to help us in figuring out what we need to optimize and make things better. But making something on the scale of 19 gauge is actually very feasible with 3D printing. So this is showing what that looks like with the electrodes sticking out. Hopefully in the next month or so we can have these be metal plated, and then we would actually have a completed prototype that we can actually test and do some things with. And again, there's a core, a hollow core all the way down there so that we can put fiber optics. So one thing I want to mention is that we actually have about 5 different designs for these devices because we don't know which one's going to work and what problems we're going to have, so we have different iterations. And we've submitted all of them, and the provisional patent has been submitted. It was about 15 to 16 pages long, so it's actually a pretty in-depth description of all the different modalities. And so now we have about a year's time frame to really put together our team and really brainstorm making these devices happen. And we're also planning to meet with clinicians at Wake Forest in June to basically, now that we have this provisional patent and we have a CDA with them, we can meet and talk about actually what we need to do and how we need to engineer it to better work for clinical utility. So we have about a year now where we really need to work aggressively to get these ideas put into practice. We're still working on our gold sulfide nanoparticles, and we plan on doing some testing ex vivo on tissue phantoms. We have some pancreatic cancer cells that we're growing now, as well as human tissue specimens. And I was hesitant to apply for anything in the fall externally because I didn't have really anything other than my ideas, and I didn't really want to share those with people outside of Virginia Tech. So I'm at the point now where I feel pretty comfortable that I feel like I could apply for some of these other funding mechanisms. And I actually think that there could be some interest in breast cancer because I have that background experience, and because I think we could also do some local therapy for breast cancer. And that's it.
Next we have Nicole Rylander. And Nicole will be talking about our carbon nanohorn cancer agent.
All right, first I also want to thank ICTAS for funding. This is a pretty multidisciplinary project where we're bringing a lot of different ideas and different faculty, so it's a great funding mechanism for us. So what we wanted to do in this project is, first let me introduce the team. My team involves myself, Tim Long, having a great chemist who's wonderful. Chris Rylander is helping us with device design delivery nanoparticles. John Robertson, who provides cancer expertise, and Ji Wang was helping us with imaging. So our overall goal is to really find ways for which we can really improve the selectivity and lower toxicity for different types of treatment.